So how do we make our diagnosis? Sometimes we find this just by physical examination. When we examine you in the office, we can take our stethoscope, listen to your neck, and sometimes we hear turbulence. And so normally you should hear nothing, but sometimes we hear a whoosh, whoosh, so like a buzzing sound or what we call a bruit. And that can kind of clue us off to the fact that there's some uneven flow in that blood vessel. That doesn't always happen, and in fact, some people who are so tightly narrowed, we can't hear a bruit at all because the flow through there is so restricted. So it's not a really specific test, and it's not really super sensitive. But that's one way we can find it. The other way we make the diagnosis is by ultrasound. So an ultrasound is just like, I don't know if any of you have seen ultrasound for babies or whatever. It's just a probe that goes on your neck, and it takes black and white pictures of the arteries and then actually takes flow, pictures of flow of blood through the arteries, and it can detect if you have a narrowed area. Ultrasound is a really great test because it's fast, it's cheap, it's easy, it doesn't hurt, there's no radiation, there's no dye, and it's a really good test. It's 80+% sensitive and specific test. So here's a picture of what an artery would look like on ultrasound. This artery is actually really nice and normal. You can see that the walls are smooth and you can see even flow through there. And then the ultrasound also shows you the waveforms of the blood passing through the artery, and we can also look at that and see how narrow your blood vessel is. There are some other ways to take pictures of your carotid arteries. You saw this picture earlier, the angiogram, where we actually shoot dye into the artery and take that picture. There are other ways to do it without putting a catheter or a needle into your blood vessels, and that's by doing an MR angiogram or a CT angiogram, and these are just examples of those pictures. So how do we treat or prevent strokes? We'll talk a little bit about the medical therapy to prevent strokes, and we'll also talk about surgery and briefly about carotid stenting. So medical therapy consists of lifestyle changes, controlling your risk factors, and meaning if you're a smoker, stop smoking. If you're diabetic, control your diabetes. If you have high cholesterol, control your cholesterol. And then antiplatelet therapy. And when most of these studies were done, antiplatelet therapy, so remember, platelets are the little tiny pieces floating around in your blood, and if those stop flowing or get caught on some plaque, they can actually form a bigger clot. And so if you're taking an aspirin or Plavix or other blood thinners, those can prevent those platelets or those little pieces from sticking around and forming a clot into a bigger clot. So that's the medical part of it, and that's a really important part of it because it can actually prevent things from starting altogether. Once you have a blockage that requires surgery, and the next question is when do we need surgery, is most of the time, we'll talk about that a little more in detail a little bit, but if you have a blockage of over 70%, that's when we start talking about doing surgery. So carotid surgery is called an endarterectomy, or some people call it a CEA. We don't need to throw too many abbreviations out, but it's an operation that I do very frequently, and we make an incision over the neck. It's about 4 to 5 inches long, all along the front part of your neck. The artery gets opened, just like you see here in this picture. The grungy plaque gets pulled out. The artery itself gets rinsed out in the middle. All that plaque gets removed, and then that artery gets closed back up, usually using a synthetic patch of some sort. So carotid surgery takes around 2 hours. It's a one-day hospital stay. Most people go home the next day and are fully functional again by a couple of weeks. So we're going to get into a little bit of data, and I'm again going to try to keep it pretty simple, but how do we know, how do we decide when to do surgery? that's an important question, because what we want to do is help people that are at risk and not have to wait until you have a stroke, but then we don't want to do it so early that we're exposing you to a risk of surgery without getting good benefits. And so it's sort of a balancing game as to when we decide to do surgery on people. So this study, called the NASCET, or the North American Symptomatic Carotid Endarterectomy Trial. So now all of you are super smart and you know that a carotid endarterectomy means cleaning out the carotid artery. It's just a fancy pants word for that. But if you look at, this word is important. So these were people that were symptomatic. So these are people that have had some symptom of stroke, or TIA. So they took like 3,000 of these patients that had symptoms of a stroke, and they split them into a bunch of groups. They did the ultrasound on the neck, and then they said, you're 1 to 49% blocked, you're 50 to 69, and you're 70 to 99, and you're completely blocked. So they put them into these little groups, depending on their degree of blockage, and then they sort of split them up into 2 bigger groups and said, this half gets surgery, this half gets aspirin. And then they decided to see what happened. And what they found was, for the patients that had greater than 70% blockage, their stroke risk in 2 years, if they took aspirin alone, so these are patients who have already had a stroke, their stroke risk in 2 years was 27%. If they were in the group that got treated by surgery plus aspirin, their stroke risk dropped to 9%. So that's pretty significant. Now, if you went to the other groups that were lower than 70% blocked, you didn't see that much of a benefit. So that's how that number got decided. If you're having symptoms and you have over 70% blockage, there you go. So there's another study called ACAS, and so I'm just going to talk to you about these 2 major studies. And that stands for Asymptomatic Carotid Atherosclerosis Study. So these are patients that have not had a symptom of stroke. So that might apply to the majority of you here in this room. So even without symptoms, they kind of split all these patients in the same sort of way. And again, the results came out that if you have over a 70% blockage, surgery is better than medical therapy alone. And again, that's for people that have not had symptoms of a stroke. In fact, the 5-year stroke risk with aspirin therapy alone was about 11%. For these are people that have never had symptoms of a stroke before. And if you had treatment with surgery, it dropped it to 3.8, or around 4%. So significant benefit from surgical therapy. So somebody asked me about carotid stenting. So carotid stenting is a newer way of treating narrowing in the carotid arteries. And, you know, the more and more technology we have, we get more and more sophisticated and less invasive ways to treat problems. And so stenting is a way of basically going up into the blood vessel on the inside and going into that narrowed area and making it wider using a wire cage or stent. And so this is a picture of that. Again, here you see your Y-shaped blood vessel. This is your common carotid artery, your internal carotid artery, and your external carotid artery. And a wire gets passed up into the internal carotid artery. We deploy a little upside-down umbrella that's shaped facing downstream, and then we sort of balloon the narrowed area and put a stent or a wire cage into the artery to push aside the plaque and make the blood vessel wider. So you're not actually cleaning out the plaque, you're sort of just pushing it aside to make the artery more wide open.